Thank you very much, Stefan. It's always a pleasure to present at the BayesiaLab conference, and I wish I could be with you guys in person down there. Um, and waiting an hour and a half has not been a problem. The presentations have been very interesting, and so hopefully mine will not stand out negatively. Let's put it that way. So I'm going to go ahead and start sharing the screen, and we will maneuver through this presentation here. Let's go into presentation mode. So you should see now some slides. The first slide says "Better Off Dead: Modeling Compliance Risk in Organ Procurement." Is that what you guys are seeing there? Excellent. So the outline is going to go like this. Though we're going to talk a little bit, just some background. Then we're going to look at some reportage, which also adds additional information about background. We're going to look at some organizations that are involved in organ procurement, and then look at pressures and incentives, some knowledge documents, and then we're going to look at some models. And this is all a theoretical presentation. It does not involve any tabular data in the traditional sense. It's still data, but it's not flat files. So here's a little headline from July 30th, 2025. Guest essay in the New York Times here at the bottom. Donor organs are too rare. We need a new definition of death. And a few days earlier, actually 10 days before that, there was a full blown report in the same paper, the New York Times, entitled "To Push for More Organ Transplants is Putting Dying Donors at Risk." So it's not just the donors that are at risk. Of course, if donors are at risk, then there are also organizations and people who are involved in the organ procurement process who are similarly at risk from a compliance standpoint. And that's the general orientation that I come from. We have a really robust compliance certification program here at University of North Georgia, and I teach the risk management course in that program. And so when I started hearing about this organ donor issue coming up this past summer, I thought, wow, that sounds like a really good topic for the BayesiaLab conference. So here we are. So as far as the scarcity of the organs, one indicator of how scarce they are is what they cost. And the uh, full treatment, all the bill charges for getting a liver transplant done are about $1 million, a little over $1 million now, based on data from Milliman, I'm sorry, which has a lot of this kind of information. A nice little app here where you choose which organ transplant you want to learn about, and they will uh, brief you on it. So, are they rare? They certainly are, and they're expensive. Whether they are too rare might depend on who you're talking to and when you talk to them. So organizations that are involved in this whole process, obviously, here in the United States, we have the U.S. Department of Health and Human Services. We've got under the HHS is the HRSA, Health Resources and Service Administration, and their division of transplantation up in Maryland. These are the guys who set the tone nationally. They are the government regulators. They've contracted with an organization called OPTN, the Organ Procurement and Transplantation Network, and they're supposed to be the ones who are really implementing, at a more practical level, the whole organ procurement process. In their operation, they have the help of other private organizations like the Association of Organ Procurement Organizations, AOPO, and members of AOPO include organizations like the Network for Hope. So we have one, two, three, four, 5 layers of organizations that are involved in the transplantation process. It's a network of hope. They are the ones that are really boots on the ground, and they go into the hospital, and they're the ones that are um, the organ procurement. Uh, what's the OPO? Organ procurement. Now I forgot the last the last letter of what they do, but oh, so it's procurement. So they're the organ procurement organization. That's what it's the OPO here. And so it turns out there are some major structural issues with how these these OPOs interact with the hospitals and the families of the donors and the recipients. And there's some serious challenges there from a compliance standpoint. So pressures and incentives, you can get a feel for how much pressure there is on these organizations and on doctors to take organs from people. This is from AOPO's website here. Their goal is to get 50,000 organ transplants in 2026. Uh, in 2024, they exceeded 48,000, and they have lots of stories about families who have benefited from organs donated by other people. So there's a lot of serious tension, and it's a very emotional subject, of course. It's also financially very lucrative for those who are providing the service and costly for those who are paying for it. And then there is the ethical question about are these organs being taken too soon sometimes? So what I did was I used BayesiaLab's Helixia assistant to develop a couple of networks. One is a semantic network that gives a broad understanding of the environment or the domain, and then the next one is a causal network. In using Helixia, one way to kind of prime the pump is to provide knowledge documents to it. And so the possibilities that were available to me, at least on a fast basis here, was some material from the Code of Federal Regulations dealing with organ transplantation. Uh, the OPTN has a policy document that is very long and has lots of words. They also have a member evaluation plan. And then AOPO has its own standards and interpretive guidelines, which are all very interesting. Finally, there is a report from HRSA on an investigation that they did on one OPO that apparently they'd received some kind of a whistleblower report that organs were being taken before people were before the donors had actually passed on. And so they conducted an investigation. They told OPTN to go do an investigation, and then HRSA also did their own investigation. More on that later. But these were the search documents, and as I was working with Helixia, um, I ran into some frustrating barriers, I suppose we should call them. Um, Frequent 404 errors and a kind of a refusal to ingest the knowledge documents that I was providing. And so, I asked the Helixia assistant on ChatGPT what was going on, and the answer that I got was, well, sometimes, if the document is too long or it's got too many redactions, like you can see in this HRSA document, there are lots of redactions, then, it won't work. And so I said, "Okay, well, I'll just use one document, one of them," and it actually did work with using just one. And I used the OPT and policies document for a little while. I may have used the EOPO standards on its own, and that worked fairly well. The problem with using just one or two of these documents, and I could only use one at a time, is that there's a lot of information that's important in all the documents, and as we'll see, um, the HRSA report is an especially important piece of information. It was fascinating how this how this developed. So these were the source documents I was hoping to use some of them. Here's an example of an OPTN policy on the conflicts of interest and who decides when somebody is dead. So this says that organ recovery and transplantation of organs must not be performed by the donor hospital healthcare team member who declares the death of the potential deceased donor. Death is declared in accordance with hospital policy and applicable state and local statute regulations. So this is a really obviously important piece of regulation right here, and they're making clear that they're supposed to not be conflicted. People that are declaring the death and taking the organs are not supposed to be the same folks. So, are you Claude? I don't know how you pronounce that. Yeah. Maybe if I spoke better French. But in any event, um, I used Claude to develop a theoretical model based on just the policy documents. I filled out the HRSA investigation report, and Claude was able to ingest on its own outside of Helixia. It was able to ingest all the documents that I threw at it, and so I said, "So go create me a network here." And so it did. Claude gave me the nodes and actually gave me the code to put this network into it's called an XDSL file that I was able to import directly into the Genie modeler, which some of you may be familiar with. You'll see some results in a few minutes here, but their key finding, this is really fascinating, uh, on this network that Claude built is network shows that multiple redundant safeguards make premature harvesting extremely unlikely. Baseline probability very, very small, right? Single failures don't create high risk due to system redundancy. Only multiple simultaneous failures across different safeguard categories could theoretically lead to increased risk. So that's their pre-HRSA investigation take on the theoretical model. Now in July, so this is a couple months after the HRSA report came out, HHS actually issued a press release saying that they had found systemic disregard for sanctity of life in the organ transplant system. So I haven't read very much into this, but I'm assuming that this is some additional investigation they went to after the HRSA report had been issued. And so, important data point. This I did not feed into any of the AI models, and so it was not considered. If I had fed it into it, we might have got a different output. So, going back now to the OPTN special review. This is the one that came out in I think it was May, and so OPTN. So this is actually this is an excerpt in the HRSA letter. They excerpted some of the OPTN findings, and so OPTN had done their special review of this one OPO, and they said overall there were no major concerns or patterns identified. While no major issues were found, reviewers pointed out a few small areas of improvement. Right, and then down below, the OPTN recommends that the secretary, that is the Health and Human Services Secretary, require the OPO to perform a root cause analysis of the OPO's failure to adhere to its own policies, including but not limited to failing to comply with a 5-minute observation rule, uh, a policy that clarifies who was a suitable candidate as a donor. That seems like kind of a big issue to me. And a policy, they're supposed to develop a policy that allows any individual to stop progression of a donation. That is the operation. People are taking stuff out of this guy's body, right? And somebody says, "Hey, wait a minute, this person is kicking or screaming or something." So they're supposed to develop a policy that allows any individual to stop progression of a donation if they identify a patient safety issue. So this is bureaucrat speak for the guy is kicking and screaming on the table because he's not really dead. That's one kind of patient safety issue. So Here's what HRSA found. So, in contrast to the OPTN report, HRSA found a concerning pattern of risk to neurologically injured patients in the OPO's DSA stemming from OPO staff practices. So we had inconsistent assessment and reassessment of patient neurologic function. Multiple patients were documented as evincing pain or discomfort during procurement events. After the OPO staff had either failed to adequately assess neurologic function or had documented findings inconsistent with successful DCD recovery. So, second, inconsistent coordination of care with patients' primary medical teams. They documented instances of OPO staff preempting healthcare teams' concerns about planned care. Inconsistent attention to independent decision making authority of legal next of kin. So apparently they were getting people that were drunk or high or whatever in the family who approved these procedures. And they said they're approaching potential donors, family members they believed to be under the influence of illicit substances or lacking cognitive capacity. So, point four, inconsistent collection and coding of patients' medical data. High proportion of patients for whom OPO records show evidence of drug overdose or intoxication were described as having mechanisms of death other than drug related. So there's a big deal here, about the number of these donor people that are under the influence of some kind of substance. Overall, the review found that 103 cases, that's 29%, had concerning features, including 73 for whom either initial or subsequent neurologic status showed features not conducive to DCD procurement. At least 8% of the patients had no cardiac time of death noted. So that's scary. So this was the HRA's findings. Obviously, they had a very different take than OPTN. And so that, I think, was prompted HHS to take a much closer look at things. So here's a semantic model that I developed. Well, I say I developed it. I just uh, I followed the BayesiaLab's instructions to develop this little model, and you can see some of the things that are there: inadequate death declaration, lack of proper authorization, miscommunication, pressure to meet transplant demand, so forth. So this is what Helixia developed, and this was produced through the Chat GPT 4.0 Turbo, I think is the engine that was used there. This is a node force analysis of the same model, and you can see what the bigger ones are: lack of donor authorization verification, sounds pretty important; inadequate death declaration of procedures, pressure to meet transplant demand. I think just as this great big globe here suggests, this is a huge thing. The demand for these organs is so big. There's just a ton of pressure on people to be declared dead so they can get their organs. This is a variable clustering. This hones in on the bigger issues. And at that point, I kind of had to stop with Helixia, at least on the semantic modeling, because I kept on getting errors back every time I try to use do procedures that required access to the AI. But great tool, I love it. I just have to figure out what's going on there in the background that is causing the 404s. So then we go to the causal model, and this is it's a completely different model, and we're not using results from the semantic model to create a causal model. There's a separate causal modeling procedure that you go through with Helixia and BayesiaLab. I'm not a fan of this particular model. I don't feel like it drills down deeply enough, and it also weirdly has in the middle here. You can see it's like a 50-50 chance of premature organ harvesting, which I don't think that that's a good prior. I think that has to be, breakdown of a bunch of stuff before you get to that point. And so I'm not really not convinced on this model, but this is the kind of thing that can be done, and I'm gonna figure out how to make this work at some point. So um, here's the prompt that I gave to Claude. And what I did was I said, Claude, go generate a model that I can then import into Genie, um, as so I can, create these Bayesian network. And so I said, please specify a Bayesian network complete with nodes, arcs, and CPTs that is coded for Genie and models the probability that an organ procurement will kill a living donor. That's kind of a maybe an edgy way of of prompting Claude, but uh, so so the Claude goes and does its thing, and then this is the basic result. So this is before considering the HRSA investigation, and you can see that they've got a down here: procurement kills a living donor. The chance of it being true is maybe 2%. That's kind of that's our prior, and so that's this is where Claude is saying, there's a very small chance that this is ever going to happen. I mean, obviously 2% is higher than the percentage that Claude is reporting in the text, but whatever. So sensitivity analysis on this Claude model, top influences on outcomes in descending order, death determination safeguards, role separation. I'm not sure what this means. I'll learn later. Procedural timeouts and verification, very important. QA monitoring responsiveness and authorization integrity. So that's where Claude thought the action was. So then I went back to Claude and I said, please reevaluate the CPTs in light of the following new document, which I just added to the project. HRS summary of its findings of the HRSA directed investigation of Network of Hope. Now, I named the organization because weirdly, even though the name was redacted everywhere else, I found that the name of the organization in a footnote. Now, I want to be clear, I don't know for 100% certain that that is the organization that was being investigated, but it's a very high probability. If you read the footnote, it seems pretty obvious. So, anyway, this is Claude's response. So I put this in. Claude says, this HRSA document reveals critical new information about actual risks in DCD organ procurement and requires significant updates to our Bayesian network's conditional probability tables. Let me create an updated version based on these concerning findings. So this is a classic example of Bayesian dating, right? The evidence updating. We're rocking along. We got all this, this policy framework and all these brilliant policies. And then the question is, are those policies really being implemented? And if they're not, how does that change our risk? And so this was Claude's more voluminous part of their more voluminous response to the HRSA investigation. So, they say HRSA investigation of a specific OPO revealed alarming patterns that necessitate significant revisions. And the original model, based on theoretical policy analysis, vastly underestimated actual risks. And so they go through and talk about, for example, uh, death determination failures were found in 21% of cases. So the original CPT says the probability of proper death determination equals no, being 0.0001, and now they changed it to 20%. Now, obviously, this is a sample of one OPO, but I think it's HHS's July communique, their press release suggests that this is a widespread problem among the OPOs. It's not just the one. And impact of HRSA finding, when all safeguards work, uh, the Claude is saying it's still, it's about a 1 in 10,000 chance of somebody being killed by a procurement procedure. With a single failure, the chance goes up to between 200s and 5%, with 2,000s and 5%. With multiple failures, it can reach 30 to 50%. Worst case, all failures 90%. So that's really the basics here. So here's again the Claude Genie model pre-HRSA. And by the way, the Genie model process here is not perfect. What you don't see on the screen right now is like about 8 or 10 nodes that were not connected by the code created by Claude. So they were just sitting over here on the right side. No, they weren't sitting on the right side. They were kind of scattered throughout the map. I had to pick them out and move them over. and took them off the screen so you wouldn't worry about them. But so it's not perfect, but it is a really interesting tool. Nothing quite as sophisticated as BayesiaLab. That's for darn sure. But it's pretty interesting. So this is pre-HRSA, and you can focus down at the bottom on the procurement, and also on these two nodes here that in the next slide, I'll put evidence in here. I'll say evidence of violation here and an error here, and you'll see that the probability here of procurement killing somebody will change pretty dramatically. So we go here, you can see we've got this is true, and there are other things in the model, of course, with back propagation that are changing as you look around. But whoops, so that's you can see that that's the impact. Okay, so let's see, what time is it? 4:09. So that's my story here, and I'm happy to respond to any questions that people might have.